Another theme that actually hasn't made it on the radar today at all, and that's private pay. We've got some amount of PAS being provided through private pay. It may be greatly larger than what we pay through the Medicaid program. We certainly know there's a lot of informal care out there, but in addition to that, people do buy and pay for assistance themselves. Now, we need to understand that, and I'll talk a minute about how we might do that. But the main point I would make here is that we've developed these infrastructures in our states to support public programs. We've got registries, we've got case management, we've got quality assurance, we've got a lot of things that try to facilitate the implementation and dissemination of Medicaid-funded PAS. For the most part, private pay folks don't have access to that. Now, that might be an oversight, or in some cases it's expressly not allowed. What are we losing by not allowing them access to that? One of the things we're losing is political support. Budgets come and go. These things become threatened. Well, if everybody has access to it, that political base is a lot stronger. But in addition to that, there may be ways, again, to stretch and integrate public and private dollars, and sliding scale payments for public programs are not all that common in PAS. What if they were? What if you could buy, as you can now with long-term care insurance, a certain amount of protection you pay for out of private dollars against a certain amount of protection you get out of public dollars? What if there was a coupling of something like that that made it an incentive for people to buy the assistance they need, and buy enough assistance that they need, not just what they can afford, but really have a better opportunity to do it. These are experiments that we need to try, and we need to then evaluate their effectiveness. The last issue I'm going to raise is one of getting out of the silo. And again, and it happens anytime we start talking about long-term care, we talk about Medicaid. And the point I'm making here is that if you're in a Medicaid system, if you're in PAS or in a nursing home or in residential care, if you're in something related to long-term care, if that system's working well, if you're managing drugs properly, if you're managing skin conditions properly, if you're managing diet and hydration and a variety of other things, if that's all working well, guess what happens? You reduce the likelihood of an emergency room visit, of a hospitalization, and of a nursing home placement. Where is that money saving? That money is saving in the Medicaid side, Medicare side. The money being spent to do that in either private pay or in Medicaid is not getting compensated for out of Medicare. Medicare gets the benefit, long-term care gets the burden. Now, if the long-term care system isn't working well, then that cost shift goes the other direction. It goes towards Medicare. So there is an inherent reason why we should be looking at both pots of money when we talk about our programs and what's working and what's not working and where the costs and where the liabilities are. Even talking to state officials, they don't want to talk about Medicare because they don't think they have jurisdiction over it. Well, they have a congressional delegation that has jurisdiction over it. They need to be brought into the conversation. But given that we need to look at both, we also need to look at it as we implement any kind of strategy, any kind of approach to delivery, of putting together data that tracks the relative effectiveness in terms of both what we're paying for in the way of assistance and what kind of risks we're avoiding or what kind of problems we're seeing, and on the healthcare side. So the type of providers that provide the care, whether it's a paid or an unpaid family member, whether it's an agency-based PAS worker, whether it's an IP, all of those things, we need to look at the relative outcomes that come out of that in terms of costs, in terms of healthcare, in addition to those that relate to more typically functionality and ADL type assistance. Similarly, with respect to the type of living arrangement, the household characteristics, whether it's a licensed housing or not, and so forth, and the level of care needs and the type of care needs that we have. And today we're expanding our ideas here, what that includes, to look at the mental health side as well as various types of other disability. We need to understand that, not because we're going to close it down, but so we can figure out what would be necessary to make it more efficient and more effective. And lastly, in the same list, On the Medicare and social service provisions, so many of our demonstrations curtail their role with regard to health. We've got social work that deals with community-based care, but we don't look at how to coordinate with physicians, how to coordinate disease management, how to bring those pieces together around a complex situation. Anybody that's tried to manage a long-term care family member in your home or even in licensed housing knows how challenging that is. Getting doctors to talk to each other is not easy. Getting medications changed and coordinated with all of the different providers involved is not easy. It takes a lot of time. We need systems that have incentives to make that happen. We need professionals that are willing to work in this way, and we need people working with family members to make it easier for them to pull this off. Okay, finally, in conclusion, and this will please some of you more than others, Mitch in particular, but we need to have data. And Martin, you too, with evidence. Finally, we get down to evidence. So we need to have data systems that link Medicare and Medicaid. One of the ways of doing this, I believe, is through partnerships with states, where we're working very specifically with the health services and social services and whatever other departments they've got to build a research strategy that links their data with Medicare data if it's applicable, and we track across systems, not silos, but across the delivery system, so they begin to see where the money is being spent, where it's being saved, and they have a basis for changing policy, changing programs, and in the end, hopefully modifying sources of payment. Similarly, with regard to the private pay side, we need to have data. We're not going to get it out of Medicare and Medicaid for the most part. It's going to have to come from some other place. And in this context, I would say the most sort of the low-hanging fruit here is on the national surveys, to modify them to include the appropriate samples for capturing this population, but also to have measures that look at need, unmet need, that look at quality of care and have quality of care indicators, and that are inclusive of all the housing types that are out there, and not only inclusive of them, but identifying them in a way that we can look at them as analytical subgroups. None of the surveys currently do that, and I know Josh is going to be launching one soon that will at least do it for assisted living. But we need to do that in the other surveys that we've got. Many of the biggest ones that are used expressly exclude licensed housing, for example, or don't identify low-income housing as a distinct element. And finally, in these national surveys, we've got to track long-term care use as well as healthcare use and the source of payment for those, so that we again can understand better how the private side of this is working as well as the public side. Thank you.